Good day. It's nice to see you here in the PISUS online course, and allow me to share to you my slides. Our topic is documentation and reporting. And at the end of the course, you as a PISUS learner should be able to appreciate the importance of reporting, to identify the benefit of reporting in different scenarios, and to be familiarized with the essential part of report. And of course, to innovate a way to create a good report. PISUS has a special part in my heart, especially with this mentor, a role model who is passionate in caring for his patient and so passionate with ultrasound as a tool for caring. Having an ultrasound in your own hand increases the speed and accuracy of diagnosis. That, I may say, is an extra power for any doctors who has that in his hand. I came across this article and I quote, "The stethoscope, reflex hammer, or pen are tools that aid my physical examination. Ultrasound is just another tool that can quickly and easily let me answer questions during my physical exam. There is nothing that feeling for an abnormal bruit can tell me that cannot be more quickly and more definitely answered with an abdominal probe in my hand." With that quotation, then I know we, as a part of the PISUS, are in the right track. Also, I could not help but to take a picture of this fellow pushing a portable ultrasound towards the ward. It's just another armamentarium, not just an ultrasound, not just in the ultrasound unit, but also as a bedside instrument. So nowadays, ultrasound are bedside instruments. And remember Uncle Ben saying, "With great power comes great responsibility." So you are here to gain the power of an ultrasound. Then let us be responsible enough in documenting and reporting our findings. Why do we need to write a report of an ultrasound? A report is something to transform a visual image into a written word. It is an information that can be understood by both members of the health team. Not everyone is adept to understand the black and white images, although most of us have an idea. PISUS aim to promote the safe and effective use of ultrasound in surgical practice. Take note, the keywords are safe and effective. And the guideline in reporting and documenting ultrasound findings considered the minimum criteria for a complete examination in each area. But take note, they are not intended to establish a legal standard of care. According to the Journal of Medicine published an article, these guidelines are considered minimum criteria. They are not to establish a legal standard. We may follow the guidelines. Ultrasound users generally follow guidelines with recognition that deviation from these guidelines will be needed in some cases, I might say in a lot of cases, depending on the patient's need and the availability of the equipment. Some equipment may be high-tech, some are just on the minimum level of requirements, so they are adjustable. And practices are encouraged to go beyond the guidelines to provide additional services and informations as needed by the patient or the colleagues who referred them. The keywords are communications, permanent records, and retrievable. Adequate documentations and communications by all members of the diagnostic ultrasound healthcare team is essential for high-quality patient care. There should be a permanent record of the ultrasound examination and its interpretation. and images of all relevant areas defined in the particular guidelines, both normal and abnormal, should be recorded in a retrievable format. Retention of the ultrasound images and reports should be consistent both with the clinical needs and with the relevant legal and local healthcare facility requirements. Communication between the interpreting physicians and the referring provider should be clear, timely, and in a manner that minimizes potential error. Therefore, it should be understood that two physicians should understand each other. It should be reported immediately or when it is needed, not tomorrow or next week. And this will lessen things that will compromise the patient. And all communications should be performed in a manner that respects patients' confidentiality. So the data privacy law is still being applied even in ultrasound communications. In a communication, we understand each other, we provide what is needed, we provide informations that are significant for the patient's care, and take note, we are not income driven. This is not our bread and butter. It's just an armamentarium for us to have a better understanding of the patient. In a permanent records, there should be a written interpretation. There should be the medical necessity and the image retention. A written interpretation and report must be complete and be maintained in the patient's medical record. The report must describe the structure or organ studied and supply an interpretation of the findings. The medical record documentation must indicate why the test was medically necessary. So there's the medical necessity. And appropriate image with measurement when clinically indicated of a relevant anatomy, pathology must be permanently stored and available for future review. Take note, availability for future review. And please note that image is now required for all procedures performed with ultrasound. And for that retrievable part, retention of ultrasound images and reports should be consistent both with clinical needs and with relevant legal and local healthcare facility requirement. As mentioned earlier, it should be consistent with clinical needs and relevant legal local healthcare facility requirement. Image must be permanently stored and available for future review. And as mentioned, there should be an images stored for every ultrasound performed. When do we create ultrasound report? As a clinician, as a practitioner, we practice ultrasound in a point of care ultrasound scanning. It might be our own patient in an outpatient, in an inpatient, or intraoperatively. It might be a clinic referral, an emergency cases that require diagnostic imaging, cases that requires images guided procedures, and so on. We as clinician knows the urgency of the procedure, and let us try an example for that. Here is an ultrasound. What are the things that comes to your mind? How do you interpret such kind of an ultrasound? Okay, let's give a few moments to analyze that ultrasound. What is the first thing that struck your mind with this image? Does it look like a car? Yes, I think. We can see densities with posterior acoustic shadowing. Okay, two of them, two densities with posterior acoustic shadowing. Okay, the thickness of the gallbladder wall and the thickness of those densities. Okay, it's a gallbladder, so you already interpreted it as a gallbladder. And those two densities most probably are stones. Probably we can note the liver parenchymal echogenicity, the biliary trees. I don't recognize them that well, but take a look at this. Yes, what about the name? These other informations are also important. And of course, this one, the organ that is involved. So as a guide, let us take a look at the following characteristics of a report. What makes a good ultrasound report? It should be concise, has logical structures, it is clear, has an accuracy, and it attempts to answer clinical questions with differential diagnosis and suggestions for further management. Take note, lengthy report does not necessarily equate to a good report. It has to be accurate. Some ultrasound panel has this. When necessarily, please take time to answer them. Official document for ultrasound images should include, but is not limited to, the following. There should be the patient's name, other identifying information, facilities identifying information, the date of the ultrasound examination, and the image orientation. Let us see some of the image orientation in an ultrasound monitor. Here are some of those orientations that might be available. An example of which are the abdomen for hepatobiliary, for the gastric, for cardio, such as into the echo, or a soft tissue, thyroid, breast, and so on. Specific ultrasound examination requested should be indicated in the document, the name of the patient's healthcare provider and the contact information. Relevant clinical information should also be included. Also include examination requested such as hepatobiliary ultrasound, fast ultrasound, or ultrasound guided aspiration of pleural fluid. Of course, the main service, if not the referring doctors, and other informations. The method of the procedure should be stated and be specified. Appropriate anatomic and sonographic terminology should be used. The use of acronym and abbreviations should be avoided as much as possible. Variations from the normal size should be accompanied by measurement when appropriate. Example, organomegaly and masses. And let us understand some ultrasound languages. When we say echocity or echogenicity, either it is a hyper or a hypoechoic structure. The texture, does it shows any coarse pattern? Echo patterns such as lace-like pattern, the size, the shape, we do the measurement. Outline, we might say there's a double walling, the arrangement, the type of tissue, showing tissue densities has been studied in our knobology, positions, locations. We also mentioned the limitations that compromise the quality of the examination, and such as the high body mass index, or a comparison with prior relevant imaging studies if available. A specific diagnosis or differential diagnosis should be included. An impression or conclusion should be included, such as I therefore conclude this might be a high drops of the gallbladder or the like. The recommendation as a surgeon, such as suggest EGD or ERCP, or suggest immediate cholecystectomy, but please take note, return the patient to the attending surgeon. Do not claim it for yourself. There will be a lot to come. The final report should be generated, signed, and dated by the interpreting physicians, and report should be available immediately, the earliest possible time upon the completion of the examination. Always update the attending physician as soon as you finish your procedure. There are times when preliminary report of the ultrasound is needed. In certain circumstances, such as immediate patient management or a particular practice environment, a preliminary report of the ultrasound result may be conveyed directly to the patient's referring healthcare provider before the final report. Preliminary report contains limited information and may not contain all the results that will be subsequently found in the final report, but it should be labeled as such. Label it, this is a preliminary report, and should be archived even if it's just a temporary preliminary report, since clinical decisions may have been based on the preliminary report. If there has been preliminary report issued, it should be documented in the final report. Any significant discrepancies between the preliminary and the final report should be communicated to the patient's provider and highlighted in the final report. By the way, I came across this article in a British medical journal on improving the documentation quality of focus or point of care ultrasound. The part that we are looking for are more or less similar to this. Patients' detailed indications, findings and conclusions, and should be signed and should be dated. What do you think? Which of this part of the report is the most neglected? Well, here is the graph of that research. It is the conclusion. Often they neglect the conclusion. They focus mostly on the pertinent findings found during ultrasound. And of course, most of them are signed. Then the patient detail, the indications, and the date are also part of those with a lower bracket. I think we are not far from their experience. Remember this one? We automatically look at the car in the middle. Those are the findings. And then the one on the periphery are the ones that are commonly left behind. Yes. When we look at this imaging, the car is the first image that comes to our mind. Those are the findings in this ultrasound. So just like that, we go directly to the findings. Now, when the training and the reorientation was done, take a look at what happened to the graph. A lot of these went up to 100%, the blue bars. But some forgot to sign, and the patient detailed already in the chart, so some of them were taken for granted. Just some suggestions. Keep a picture of your sonographic findings properly labeled. Make this data available in case you need to show it to the patient or the concerned doctor. Discuss the findings with other attending physicians, especially during MDTs, and please keep in mind the data privacy law when keeping all these pictures and data you have. So, in summary, the guidelines for reporting and documentation is not intended to establish legal standard of care. Whatever is needed by the clinician, whatever is useful and informative, if you need to deviate, go on. If you need to go beyond that guidelines, as long as it will help the patient and the colleague who requested for it, and then go ahead. There is no limitations. communicate properly with your colleague, and be conscious of the data privacy law. As they say, like a bikini, hide what needs to be hidden, but reveal the essential. That ends my report. Now I can entertain any questions. Thank you very much. These are my references.